Welcome to The Bridge, Your Health, Your Voice, the official podcast for the University of Maryland, Baltimore School of Pharmacy Patients Program. The Patients Program is the bridge between the community and researchers. The Patients Program created this partnership to help researchers listen to the community's voice in order to build a bridge to an effective learning healthcare community. Here's your host, Rodney Elliott.
Hello, Mike Scott. How are you?
I'm all boring and grumpy. Well, not really, but everybody laughs when they say it.
Boring and grumpy? I don't think so, Mike. From the emails that we've exchanged back and forth, our brief conversation we had, there's nothing boring or grumpy at all about you, Mike Scott. As a matter of fact, you are one that wears many hats. We're going to dive right into with your role with the ASPI, the Active Surveillance Patients International Group. You worked with the Patients Program before. You are one of the original graduates of the PPA back in 2022. So, Mike Scott, believe it or not, this is going to be an interview where we're going to talk about some of the things that you've discovered along your journey, why you do this work. But at the same time, we're going to share about how important it is to you being an advocate for folks and not necessarily being the superhero or putting all the light shined on you, but you are someone that speaks for folks.
Well, I speak to folks, and some of them speak to me too. I think it's important for you to understand. I worked professionally in healthcare communications for most of my working life, and my entire working life after I moved from England to America. And I became an accidental advocate because somebody walked into my office one day in early 1994 and said, "Do you know what Netscape is?" And I said no. And so he looked at me, he said, "Well, I'll come back in a couple of months and show you." So I think it was just before Christmas 1994, he walked back into my office carrying his computer, put it down on my desk, and showed me the Netscape website. And I took one look at this and I said, "My God, we can finally communicate directly to patients." There's my immediate reaction.
Netscape in 1994. That was my senior year, maybe my freshman year in college, and that's when I was introduced to the internet. So right. I kind of know what you're talking about, right? That was a difference for me because before, all my information back then I was getting was encyclopedias. I'm definitely dating myself right here.
No, you're not, because if you think you're dating yourself, think how I'm dating myself. Prior to that, for a patient, it had been incredibly difficult to get good, sound healthcare information because you're right, they would have to go and look in dictionaries and encyclopedias, which were all out of date by the time they were printed, let alone by the time you read them.
Yeah.
Whereas now I was able to say, okay, we're going to build, and this was how I got involved with prostate cancer. I'm going to build a healthcare website for patients. And because I had learned an enormous amount about prostate cancer, because I was busily teaching physicians how the diagnosis and management of prostate cancer was changing, I was able to build a relatively simple website at first for patients.
Okay.
With sound basic information about the way prostate cancer was diagnosed and treated, but it also did something else. It included something called Ask Arthur, and you could ask Arthur a question about, anything you liked about prostate cancer. And Arthur would give you an answer, and the only condition was that the answer would be public. You wouldn't have to give your name or email address or anything if you didn't want to, but the answer would be made public so that everybody else could learn from Ask Arthur as well as just you. And to my astonishment, this was in about mid-1995 by the time we got it up and running. And to my astonishment, by about 1996, I had discovered that an enormous number of people around the world had Ask Arthur as their homepage.
I remember Ask Arthur. Mike, we're going down a time, we are really going down a time capsule right now. I remember Ask Arthur in some realm around my psychology class, freshman, sophomore year. That was a resource for us. And my TA, teacher's assistant, she would always leave us that opportunity to kind of go to ask Arthur about questions. So this is great because that's where your inspiration was birthed. That's where your inspiration came from to build a website. 4 years later, have realized that a lot of folks around the country, around the world who are dealing with the challenges around prostate cancer now have a resource. Are there any other stories that you can share or experiences that has deeply impacted you during your advocacy work? Because you were talking 20-something years ago where you created a website, then you have 4 years of data, so to speak. I'm pretty sure now you got tons of stories along you.
During that 4 years, I also worked with a guy called Mike Katz, who subsequently became the first director of the NCI Directors Patient Advisory Council. Mike and I built the first version of the International Myeloma Foundation's website as well. He provided the knowledge about myeloma and I provided the knowledge about getting it up on the web. That was shortly after I'd actually become a director of the International Myeloma Foundation. But again, that changed the ability of people to get information about myeloma. There had never been anything about myeloma of significance on the web before, specifically for patients. You can go and look at that site now. I no longer have to have anything to do with it, but it is a mountain of knowledge about myeloma. And during the last 20 years, we have gone from having one drug that could be used to treat myeloma to, I think, now something in the region of 15 to 20.
That's tremendous and fantastic. And I'm glad that you not only been a part of it, but be able to actually share this information, these resources for folks all over. And when we talk about some of the challenges that this group, that this community faces, what are some of the misconceptions that are surrounding the prostate cancer, particularly when it comes to finding information about it, finding, what works, what doesn't work, what new research is out there, what medicines, what are some of the...
prostate cancer is a complex disease because there are all sorts of different types of prostate cancer. Yes. Very low risk that you probably never need to get treated for at all. There is very high risk that you need to get treated for urgently, and every spectrum in between. One of the problems is that the baseline diagnostic test for prostate cancer, called a PSA test, is not a very good indicator of your risk level. You need to get additional information in order to be able to assess your risk level and then come to good decisions through a process that's now called shared decision making.
Yep.
And this has a lot to do with patients becoming their own advocates and knowing how to work in a constructive way with their doctors, because early treatment of prostate cancer comes with side effects. They can be severe or they can be mild, but it definitely comes with side effects. And if you can avoid treatment for a period of time, obviously then your quality of life doesn't get affected early in the stage of the disease. But all of this is complicated because there are risks to both sides. You could miss getting treated early enough. You could get treated too early and never need it. And it's very hard to make these decisions. And the one thing I say to every patient, if I talk to them about prostate cancer, is I can't tell you what to do.
Yes.
I can only help you to understand what the options may be, and then you need to talk to probably 2 or 3 different doctors about how to assess that risk in your particular case. There are no rights and wrongs related to the treatment of prostate cancer.
It's about finding information and quote unquote doing your own research, but
exactly
where do folks go to get that? And earlier you mentioned you're talking about being an accidental advocate, or now you're talking about opportunities where when you get this information, you're advising some of the folks you're talking to make these shared decisions by talking to the doctors, caregivers, loved ones.
There is no one good site that can help you. Probably the best one is the one that's run by the Prostate Cancer Foundation from Los Angeles. I used to provide a site that was very specifically for patients, but frankly, after doing that for nearly 20 years, I mean, it took an enormous amount of my time every day, and I haven't done. And I've decided I needed to move on and do some other things because I had achieved the major goal that I wanted to achieve. And that was, this is a lot of what I got the award for, persuading the urology community as well as the patients that a form of management called active surveillance was a perfectly viable option for the treatment of men with early and either low risk or moderately low risk prostate cancer. In other words, you didn't get any treatment. You just got actively monitored on probably a 6-monthly basis to make sure the disease was not progressing.
How was that received by the community, Mike? You're talking about being active because as men, we don't, if it's not bleeding or if it's not swollen or if it's not, we're not going to the doctors. We're not going, but you're talking about actively surveillance. How did you persuade?
Well, you must remember that back in about 1980 something or other, the late 1980s, when the PSA test first became available, urologists would tell patients, your PSA is rising, you've got to have your prostate out now.
Wow.
And they believed it. I mean, the doctors believed it. It took an awful long time for everybody to understand that there were nuances to different types of prostate cancer. And, surgeons want to operate. It's the way they think. It's the way they behave. So the idea that one could just monitor patients was not originally mine. The idea that you could just monitor patients originally came from a urologist called Jerry Chodak, who worked at the University of Chicago. And I saw an early lecture of Jerry's where he basically was saying, we don't need to treat all these people immediately. And that went down like a ton of bricks in the urology community, and whatever it was, about 1987, I think.
I can imagine. If someone says don't treat them, I don't have no work. I don't have no jobs. I don't know about that.
So by about the mid-1990s, 2 or 3 different groups were actually trying to work out how to measure whether active surveillance was a good idea.
Okay.
And one of them was a group up in Canada run by a guy called Laurie Klotz. Another was a group in Baltimore run, I did forget the name of the physician, but it was at Johns Hopkins. And the third and the biggest one was a study that started to get done in England called the PROTECT trial. And the PROTECT trial actually randomized men with an elevated PSA result and a confirmed biopsy that was positive for prostate cancer to 3 different types of management. They could have surgery, they could have radiation therapy, or they could be actively monitored.
Okay.
They have now followed those patients for nearly 20 years.
Wow.
When they published the 10-year results, which was the first publication, it clearly showed that there was no difference for the low and moderate risk patients in how they were managed over that period of time, given that they could still be treated later. I mean, in other words, if your PSA started to rise too fast or anything like that, you could still have treatment, and the patients could then choose the treatment they wanted. But they could be actively monitored for a significant period of time, and it was a long period of time. I mean, I can't remember what the median time was, but...
But they had options.
Sorry?
But they had options, so it sounds like
they're
provided with options, right?
Exactly. And, I mean, there's one patient I am aware of, actually more than one, 2 or 3 patients I am aware of who've been being monitored for upwards of 15 to 20 years, and they still don't need treatment.
Wow, that's awesome. That's awesome. Ladies and gentlemen, I'm Rodney Elliott here, engagement specialist with the Patients Program, and we're having a great conversation with Mike Scott. He's a PPA graduate, 2022 PPA graduate. He actually won an award, and he talked about it here in this conversation from the Active Surveillance Patients Intensive Group. And Mike, we're going to shine a small light, not a big light, just a small light on the award that you won. Can you tell our listeners and our viewers about the award and what significance that it, I guess, gave to you, but also lets you be that accidental advocate that you always talk about?
The award was given to me by Active Surveillance Patients International, which is an organization that I didn't help to found, but I certainly was involved in its founding, and which attempts to educate men about active surveillance as an option for prostate cancer. Now, I will tell you that since active surveillance became a recognized way of managing prostate cancer for the right type of man, other forms of cancer that are also relatively low risk and can progress quite slowly have also started to use active surveillance as a form of management. Mm-hmm. And I've told Active Surveillance Patients International that they should set out to provide information to all of those other forms of patient as well. Whether they will do that or not, I don't know.
I love it.
But basically, I got the award for being a pain in everybody's ass and encouraging everybody to look seriously at active surveillance as a form of management for prostate cancer. And, you know, I was not the person who made it happen. Other people made it happen. Jerry Chodak made it happen. Peter Albertson made it happen. Laurie Klotz made it happen. And above all, the PROTECT trial made it happen, because the PROTECT trial provided data from a randomized trial in over 1,500 men, over a period of 20 years that clearly showed that active surveillance clinically was a perfectly reasonable option for the right type of patient.
Mike, every now and then here at the Patients Program, I run into, or our group, I would say in general, runs into folks who are champions for a cause, who don't take no for an answer, or who maybe stay on the call a little bit longer to have a deeper dive conversation about a particular project. So here at the Patients Program, when we hear about someone who does some fantastic work in the community, we do a little snap here and show them love and give them their flowers. So Mike, kudos to you for the work you do and being that stubborn guy for a moment there, because as you can see, your work has birthed or been very fruitful, not only for folks in prostate, the folks who are dealing with prostate cancer, but also for other cancer challenges that are out there as well. So again, kudos to you for that. Again, I talked about it.
Thank you. I should say I just felt that I was doing the right thing at the right time. I mean, I didn't see myself as being any sort of hero in all of this, and I still don't. I think it was simply that I was the right person at the right time, and I had the willpower to stick to my guns. And I knew how to talk to the urology community about this, and I knew who to help to stimulate to keep looking at this further. So I got lucky in that respect. I also got lucky in finding a patient with low-risk prostate cancer called Howard Walensky, who is one of the founders of Active Surveillance Patients International. And I put him on a panel at an ASCO meeting on genitourinary cancers, where the chairman forgot to ask him any questions, and Howard then went on a rant for about 10 minutes about why active surveillance was so important. And Howard has now basically taken over from me as being the premier advocate for active surveillance in America.
I think you like that too.
I do. I thought
something about that tells me you like that. That's great, Mike. Before we got out of here, Mike, I got a couple more questions and then we can kind of wrap it up. PPA, that was something that the Patients Program started to kind of give folks like yourself who are adamant about particular causes and have different roles, so to speak. PPA is compiled of patients, caregivers, advocates, insurers, pharmaceutical folks, everyone that's around that space when it comes to patient care. Can you talk a little bit about what you thought you were going to get out of the PPA and then what you actually did learn or get out of the PPA?
So I should first explain that I met Daniel Mullins at a date that I can no longer remember. We had both been invited for different reasons to come to a meeting about an ongoing trial of the use of proton radiation therapy in the treatment of prostate cancer. And after that meeting, I started to talk to Daniel about how we could get PCORI money to try to spread the word about the use of active surveillance in prostate cancer. And we got a Eugene Washington Award in the end. Basically, Daniel did a lot of that work. And so we were able during COVID to hold an online meeting with, I think, probably about 70 or 80 different prostate cancer patients to try and find out what patients wanted in next stage trials for the management of prostate cancer. Now, some things came out of it. As far as I know, no trials came out of it at that time, but it did help, I think, to get patient input on the subject. And so when Daniel told me they were starting the patient's professors program, I joined up, not because I necessarily thought I was going to learn anything new and exciting for myself, but because I knew I had a lot of background that might be useful to others.
Yes.
And it didn't mean I wouldn't learn something, and I have learned something. I've learned quite a lot of things, but I look at this whole thing very differently probably to the average patient, because for me, this is about how do all of the different communities successfully talk to each other, the research communities as well as the patient communities, as well as the insurance communities, as well as you name it. And bringing all those groups together to have a suitable patient perspective on any form of either research or just intercommunication, to me is important. This is about making medicine patient-centric again.
I love it. I love it, Mike. That is what one of the ideas of the PPA back when we started in 2022, and we just finished up our third cohort this year, 2024, and the responses that I've gotten from or have been a part of hearing from participants have been similar to what you just mentioned, right? Going into it not expecting a whole bunch or maybe not expecting to learn that much, but the fact of the matter that you have an opportunity to be in these groups, in these breakout sessions, in these meetings, having these conversations and dialogues around a shared topic just brings so many different perspectives to an issue, but all with providing valuable, truthful information, but also a resource. So kudos to the folks over at PPA. As always show them love here on the bridge. And for when we have or run into guests and participants like Mike, who is a accidental advocate, who does the right things at the right time, it's not surprising that you do win awards, such as the award you won from Active Surveillance.
There was one other thing I would say about PPA, and I've told other members of the staff about this. We have started to form a community of the graduates of PPA, but we aren't yet a community because we are dependent on PPA to bring us together for different things. Whereas I think it's time for us to start to work together as the graduates of the PPA, and we don't necessarily need PPA to stand over us while we're doing this. I mean, even if we were just holding a weekly teleconference that was open for all graduates to come to if they wanted to, where people could say, I've been having this or that problem and I'm trying to do this or that. And other people would be able to say, oh, well, I've had a similar problem. This is the way I approached it. The ability for, excuse me, the ability for the graduates of the PPA to have professional standing and to work towards some form of certification, I think is very important and particularly important within the pharmaceutical industry, where it is really important that we have people like this working. But they aren't doctors and they aren't researchers. They don't have PhDs and MDs after their name. They need that stature to allow them to be seen as a credible partner in the process of working with the patient community.
Mike, you make it hard for folks not to give you awards, dude. You make it hard for folks not to give you accolades because all these ideas you come up with. That right there reminds me of one of our patient partners. We had a meeting, and I'm remiss for not remembering her name, but she said something along the lines of what you just talked about, right? You could have conversations with doctors, researchers, they have all those letters behind their names, but just as important are the LE behind the regular person's name, the LE, the lived experiences. Those experiences are just as valuable as folks who may have studied or got degrees. So, when you talk about those sessions or having those meetings post PPA, I know that's something the PPA wanted, that they kind of knew that was going to happen, because during that 5-week, 6-week course, man, there are opportunities where, folks have learned so much and wanted to keep the conversation going. So I hope that you guys do that. I hope that is done. And if you can reach out to folks at the PPA, I know they'll be able to maybe at least help you guys and get you started.
Well, I have made this pitch to everybody I'm aware of, from Daniel downwards, at this point in time. And so if something doesn't happen fairly soon, I may just do it on my own.
Mike, it's been a pleasure. Thank you for your time. Man, this was an awesome conversation. And I look forward to seeing your name in emails and look forward to possibly seeing your name on some grants. But I know this won't be the first and last time I'll be seeing you and you'll be dealing with the patients program.
Well, thanks for your time today, Rodney, and I appreciate the opportunity. And I hope this interview will be of use to at least one person. If it's of use to one person, I've done something useful today.
You like it, I love it. Thank you, Mike. Appreciate it.
You take care now.
Thank you for listening to The Bridge, your health, your voice. To learn more about the Patients Program, visit our website at www.patients.umaryland.edu.